Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll,
Here.
Senator Douglas,
Present.
Senator Elkins, Senator Funky Fromeyer, Senator Nemes,
Present.
Senator Tishner, Senator Wise, Representative Bentley, Representative Bratcher, Representative Bray, Representative Burke, Representative Callaway,
Present.
Representative Camuel,
Here.
Representative Dotson,
Present.
Representative Duvall,
Present.
Representative Gordon, Fraser Gordon, Representative Justice, Representative Neighbors,
Here.
Representative Rayburn,
Here.
Representative Raymer,
Here.
Representative Riley, Representative Rorks,
Here.
Representative Sharp,
Present.
Representative Wilner,
Here.
Representative Witten, Co-Chair Mosier, Chairman Meredith.
Present. Again, we do have a quorum. Constituted to do business, so we will proceed. Just a quick note. This will be our last meeting for the health services during this interim. It's our 6th meeting. And they're not here today, but would hope that each of you would reach out to Representative Danny Bentley and Representative Jacob Justice. This would have been their last meeting. Neither one of them's here today, but we want to thank them for their years of service on this committee, and particularly Representative Bentley. I came in the same time he did back in 2017, and he's been a strong voice for healthcare throughout Kentucky, and we want to wish him the best going forward. Approval of minutes. Is there a motion?
Motion.
Thank you. You're on top of it today. Appreciate it. Is there a second?
I'm here for you.
I can tell. There's a second. All those in favor vote aye. Any opposition by like sign? All right, thank you. Slight deviation in our agenda in that we have a hard time maintaining a quorum sometimes, so I don't want this to get overlooked. But we had several administrative regs that were also distributed to you folks. In addition, we have 3 agency amendments that are proposed, and we'll need 2 motions if everybody finds these in order. 3 amendments on the agency amendments proposed. So with that, are there any objections to the other proposed amendments or anything anybody wants to discuss? If not, then they would consider reviewed. Now, with regard to the agency amendments proposed, we have 3 again. Definition for hemp-derived cannabinoid products. Also processing, registration for processing, manufacturing, storage. And the last is the initial renewal applications for the cannabis business license. And I think the substance of this goes back to the fees that they're required to pay. There's some confusion of whether this was a one-time fee or had to be paid every year. And Cabinet made clarification that's a one-time fee. So it has gone through administrative reg and they improved. So any questions, concerns about that? If not, I'll need a motion on each one of those. Let's do 902 KAR 45001. Is there a motion? Thank you. Is there a second? Second. Thank you. All those in favor say aye. Aye. Any opposition by like sign? That passes. Second one is 902 KAR 45021. Is there a motion on that one? It's got to be Monday morning here. Thank you. Motion and a second. All those in favor say aye. In opposition? There being none, that passes. Third and final, 915 KAR 1010 regarding the renewal and initial renewal application for licenses. Is there a motion for that one? I heard a so moved in a second. All those in favor say aye. Aye. All right, thank you. Now that we're all awake, we'll jump right into the agenda. Again, an editorial note. You may recall that we previously had a Medicaid oversight committee that I think it was Senate Bill 42 when we did a reorg that was eliminated because we split health services Health and Family Services in two separate committees. And we thought we can conduct the business regarding Medicaid oversight within the this committee. A little bit of a challenge, so to that end, this meeting is pretty much dedicated solely to Medicaid and Medicaid issues. So that's why we have a very lengthy agenda specific to the Medicaid program. But first, I'd like to go to agenda item 3, which is the new Legislative Research Office, Commission Office of Health Data Analytics. And Stephanie, if you're here, I'd ask you to come forward. A lady who really needs no introduction, but Stephanie Wood, you've been here many, many times. You would please identify yourself for the record.
Good morning. Can you hear me okay? Great. So thank you very much for giving me the opportunity to introduce myself. My name is Stephanie Bates. I am the Assistant Director for the brand new Office of Health Data and Analytics here at LRC. The office is really meant for to be a resource for the General Assembly, every member of the General Assembly, to look at health-related issues, including Medicaid, and to really take and advise, give information, take data and reporting that you may already receive or that you receive, look at that, and provide recommendations. So with that, that's my short introduction, but I'm happy to answer any questions.
Senator Berg.
Good morning, and thank you. This sounds right up my alley.
Oh, good.
Will this data be available to the medical community? Like, can we call in and ask how many cases of breast cancer were diagnosed in the state last year?
If we have it, or we can request it. So yes, just any questions that you as a member of the General Assembly have, you can come to me and we'll see if we have it already. We'll give it to you, and if not, we'll ask for it.
Okay, and so my question goes beyond that.
Sure.
Not just as a member of the General Assembly, but as healthcare providers in the state that need access to this type of data. Will that be available? Like last meeting, Dr. Jones presented us data that was literally 4 years old.
Right.
Irrelevant. I mean, I would have not presented it because it just has no meaning at this point. Will healthcare providers be able to reach out to you and get up-to-date data on incidents of colorectal, incidents of breast, how many car accidents we have, the type of data that we need as healthcare providers to make sure that we have a system in place to address it?
So I guess my answer to that is maybe let's talk about it.
Okay, great.
Because I work for you all, right? I'm working for the General Assembly as a nonpartisan employee of LRC. So I think we can talk about it. And anyone that wants to ask that, let's meet and let's talk about it.
Awesome. Thank
Okay?
you. Thank you.
Thank you.
Senator Frankie Fromeyer.
Thank you. I was also raising my hand for Senator Nemes, but a question as well. So I had a constituent reach out about severe blood clots on her father-in-law's body, and they seem to, in his lungs in particular, and they seem to have arisen in the last 2 years. He's a very active farmer. So how then would I take that request from this particular public health nurse? That's what her role is, but this is her father-in-law. How would I then be able to help guide her? She's asking a really tough question, but she's asking it from the public health nurse perspective, and then frustration that she's lining it up in direct correlation with the timing of his first COVID shot and his second COVID shot. And she's feeling pretty strongly about it. And she's asking me, what are you going to do about this? And this was all the way up until midnight last night that I'm back and forth in conversation with her. Can you guide us a little bit on how you'll be able to help us assemble information so that we can determine what's our next step?
So I think it's a similar answer to what Senator Berg had asked. And so let me back up and say that my first day on the job was October 21st. And so this office is brand new, and so we're going to build it from the ground up. So I think that situations like that and others will have to be taken from, on a one-on-one basis. So if you wanted that information, just reach out to me. We'll sit down and we'll talk about how we can support you in responding to them. Okay?
Stephanie, if I could, let me add that your position is evolving.
That's correct.
The first thing we're focusing on, I believe, is the rebasing for our payment system, which was authorized in the last budget session. So I would think probably for the first several months, you're going to be consumed with that. I think we'll hear more possibly from Medicaid about this, but Medicaid was directed to rebase, and we have a separate study to look at that as well, so Stephanie will be doing that. And I think as we start to look at health policy in a broader scope, that's what we'll look to Stephanie for, to give us direction and see what information might be available. If it's not available, how we can collect that information. So I'd ask everybody's patience with her as she defines her new role. But personally, I'm very excited to have her. It's the first time that our legislature has really had someone who can do a deep dive into these issues that we're always tackling with, such as you mentioned, Senator Funky Fromeyer. So great to have you on board, and we look forward to working with you. And I'm sure when we get into the session, we will be hearing from you and in the next interim as well. So welcome on board. Glad to have you here.
Great. Thank you very much.
Anyone else before she excuses herself? Yes, I'm sorry. Senator Nemes.
Thank you, Mr. Chairman. It's more of a comment. Thank you for doing what you're going to do. The legislature needs all the information we can get. But let's be cautious, not to you, but to the legislature, on setting up something and paying for something that's going to go public in that. We have Kentucky Stats, we have the universities and this and that to do that. You're, I think, in department to help the legislature, not to reach out. That's an expense that we need to be cautious on going to. Thank you.
Thank you, sir. Appreciate it. Co-Chair Moser.
Thank you, Mr. Chairman. I apologize for walking in a little bit late, but I am very, very excited about this office. I have been requesting information for a few years, especially when we're talking about Medicaid rebasing. We also have, and I'm excited at the possibilities. I think that this could become a central repository for health data. I think it needs to be user-friendly, and of course, as your office evolves, you'll decide how that happens, who can access the data, how it interfaces with some of the things that we already have. We have KHI, the Kentucky Health Information Exchange. How will your office interface with KHI? Will KHI need to exist? Are you looking at claims? Do you know yet? No.
Oh, there it goes.
Yes.
So I don't know, to be honest. So one of the things I'm doing today is meeting internally to talk about putting structure around that and having some sort of, first off, data governance. We don't need to create something new, to your point, that already exists. And so it is literally being built. As we get things in, we will put some structure around what that looks like, because it does not exist in a big way around health data at LRC. But so I'm confident that we'll be able to put some structure around it and report that back to this committee.
Wonderful. Thank you.
Thank you for being available to us this morning. Appreciate it.
Absolutely. Thank you.
Next item on our agenda is the big bullet point here. That's the state of the Medicaid program update. And I'd say we have various players that will be coming to the table. Just remind the committee again that when we had Medicaid oversight, we were statutorily required to have at least 4 meetings each year to provide this oversight. And since we don't have that committee, then we're a little bit limited on what we can do. You see on the agenda, there's kind of a laundry list of items that we've asked the commissioner and her people to address today. I don't know this has to be an all-inclusive list, but these are things that we heard from members of our committee, also members of the Senate and the House as well. Some issues that are on the forefront right now, but again, during the course of the meeting, if time presents itself, if there's anything else you'd like them to bring up, please feel free to raise your hand. We'll try to do that. But with that, Commissioner Lee, glad to have you this morning. If you folks would, please identify yourself for the record, and we'll proceed.
Good morning. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services, and I'm also the current President of the National Association of Medicaid Directors.
Good morning. I'm Steve Bechtel. I'm the Chief Financial Officer for the Department of Medicaid.
Good morning. Angela Sparrow, Behavioral Health Supervisor with Department for Medicaid Services.
And as you can see on the agenda, we did have Deputy Commissioners Judy Cecil and Hoffman. They had urgent matters that they had to attend to today and will not be here today.
All right, thank you. Please proceed.
So this is just the organizational structure for the department. We do have the Office of the Commissioner, and underneath the Commissioner, we have 7 different divisions. The Division of Quality and Population Health is exactly what it stands for, Quality and Population Health. We want to make sure that our members are receiving quality services that are leading to improvements in their health status. The Division of Program Integrity oversees provider enrollment and also oversees fraud, waste, and abuse issues. The Division of Long-Term Services and Supports oversees our 1915C home and community-based waivers and our long-term care facilities, nursing homes. The Division of Fiscal Management, again, is exactly what it stands for, is fiscal management. They oversee all of our financials. The Division of Healthcare Policy oversees policy related to the implementation of services that are delivered to Medicaid members. Health Plan Oversight is the division that oversees managed care organizations' contractual obligations, as well as the Kentucky Health Benefit Exchange. And our Division of Information Systems helps us with all of our technology needs throughout the department. Currently, we have 1.4 million members enrolled in the Kentucky Department for Medicaid Services. Over 600,000 children are enrolled in the program. That is more than half of the children in this state. Kentucky currently has 1.1 million children under the age of 18. Over 600,000 of those children are enrolled in either Medicaid or the Kentucky Children's Health Insurance Plan. We have 485,000 expansion members. Those are members who are at or below 138% of the federal poverty level. We have 69,000 plus enrolled providers. Those providers are both in-state and out-of-state. And in 2024, our budget combined administrative and benefits was $18.5 billion. Our enrollment trend, as you can see, has been going down. This is due to the public health emergency due to COVID. During the COVID public health emergency, we could not disenroll anyone from the Medicaid program. And as part of that condition, we were receiving an extra 6.2% it's called FMAP, Federal Medicaid Participation, but it's basically the amount of money that we receive from the federal government. So during from the Centers for Medicare and Medicaid Services. So during the public health emergency, we received an additional 6.2% FMAP in order to keep all of those individuals enrolled. That was a condition of receiving those extra funds. In April of 2023, we began unwinding from the public health emergency, and as you can see, our enrollment trends began to go down until we get to where we are today, and that is, again, a little over 1.4 million individuals in the program. This is just a snapshot of our Medicaid benefits budget in 2024. You can see our total expenditures broken out by general fund, restricted, and federal funds. And then you can see our 25 budgeted projections. And I would have to say that our forecasting model was spot on for 2024. Our expenditures were within less than 1% of what we actually had predicted. This is just a breakout for those of you who may be a little bit more visual. As you can see, the biggest spend in the Medicaid program, that $14.3 billion, goes to the Medicaid managed care organizations. We currently have 6 Medicaid managed care organizations delivering services to 90% of our population. The other 10% of our population is enrolled in 1915C home and community-based waivers or in long-term care facilities. And so the cost that you see over in the breakout is mainly distributed for those individuals who are in our fee-for-service program. Again, those long-term care individuals in home and community-based waivers. Steve, is there anything you'd like to add to this slide?
No, I'll just say that the managed care, it's payments to and through the managed care organizations. And what I mean by that is the through pieces. As you all recall, there's some directed payments that we've been instructed by the General Assembly to process. And so we have to pay those in order to get the average commercial rate. We have to pay those to and through the MCFs.
And then I will turn to my Chief Financial Officer for the remainder of the budget presentation.
Yeah. So this slide here will show you that compared to 23, state fiscal year 24, our expenditures and the benefits grew by $1.6 billion. That's about a 9.8% increase over the previous year. Majority of that you can see is on the managed care line, but I will caution you to think that was because of expanding the what we call ATRIP, Hospital Rate Improvement Program, to cover outpatient services. So when we did that, that increased our spend. And I'll have a slide here in a second that shows that illustrates that. The other big ticket item was in our fee-for-service, and that was due to some nursing facility and the waiver spend increase. As you may recall, we were instructed to increase rates across the board for all of our waiver services except for Model 2 for about 10% in state fiscal year 24. And we'll show that here in a second. Next slide. This is the directed payments that I was talking about. Approximately 30% of that $14.3 billion that we showed on that pie chart, approximately 30.5% or $4.3 billion is paid across these three programs. I mentioned the Hospital Rate Improvement Program. You can see the substantial increase there, $1.1 billion. That's due to expanding that to the outpatient. That state funds are covered through the hospital tax. So the state funds are covered by the hospitals. Ambulance Provider Assessment Program, it just had a slight uptick. That's due to utilization increase. That as well is covered through the provider tax that we established for ambulance providers. And then the University Directed Payment Program, it grew because of a couple hospitals got added to the program, as well as some utilization increase. So, but that program is funded through what we call an IGT. It's intergovernmental transfers. Those by public funds, they pay the state match of that. This is going to grow even more next year. We have a preprint that we've already submitted to CMS, as you all have instructed us to do in Senate Bill 280. And that is to cover our trauma centers, to expand that, to expand another directed payment. So that is currently in process and currently being reviewed by CMS. Next slide. And then I mentioned the waivers. In aggregate, you can see about a 10.3% increase from 23 to 24. Across all the waivers. Some of them, you'll if you look at each line, like SCL, Supports for Community Living, it wasn't quite 10% because if you recall, we also had a 50% clause in there in 22 that we had to increase residential stays. So the Supports for Community Living and the the brain injury. Some of that, the acquired brain injury, long-term care, those two items, those two lines, the reason why the numbers are not quite up to 10% is because the 50% for those residential stays is already included in the base of 22. And that's
Thanks, Steve. Just a few minutes ago, you did hear me mention that we currently have 6 managed care organizations. Due to recent court activity beginning January 1st of 2025, we will have 5 managed care organizations. Anthem will no longer be a managed care organization. We received that information, and we have developed a transition timeline as well as a plan to ensure all of our members are transitioned to another managed care organization to promote continuity of care and make sure that they don't have a lapse in coverage. We have, as you can see from the timeline, we were notified on November the 1st. We are not going to be reassigning new members to Anthem as of November the 9th. November the 10th, we have system changes to be able to reassign individuals who are currently in Anthem. We will be sending various notifications out to members and providers. And then again, on 1/1 of 2025, members will be in a different managed care organization.
Commissioner, before you proceed, I'd like to entertain questions specific to the Medicaid budget, because we've got a lot to cover here. Just, to that end, Senator Tishner.
I didn't know I'd be first. Thank you. Thank
Lucky
you all for
day.
being here. So I'm looking at the Medicaid enrollment trend has significantly dropped, but and obviously it's going to level a little bit because a lot of that was the COVID regulations that were in place. But $1 billion increase in the budget, is that what do you anticipate $1 billion increase for the 2025 fiscal year with numbers? Enrollment has seemed to have leveled quite a bit.
the individuals that have been disenrolled are low utilizers, people who weren't really seeking care. They are also, we have a higher acuity levels of those who remain that are still here. What that means is higher cost, higher services, a little more, we still, the sicker population, I'm just going to be bluntly honest, the sicker population stayed on, and the non-sick is the ones who are leaving.
So $1 billion increase, even if the membership enrollment stays the same, what is contributing to that significant increase in the budget, expected increase in the budget?
Just utilization, increased cost of healthcare. The healthcare cost is just expanding largely.
Yeah, there are various factors that we can't predict typically, but one thing that we have noticed is definitely an increase in pharmaceutical spend, high-cost drugs, those sorts of things that are contributing to an increase in expenditures. There's also an increase in behavioral health spend that we will talk about in a little bit, but basically, as Mr. Bechtel said, the members who are in the Medicaid program are high acuity members. Just for informational purposes, those individuals who are in the Medicaid program are aged individuals, 65 and over, long-term care, blind, disabled, pregnant women, and children. And so the cost of care for those individuals is typically a little bit higher than those individuals who don't have various disease states that we see in our Medicaid population, high utilization or high acuity needs in diabetes, heart disease, those sorts of things. So the acuity levels of the Medicaid member is definitely contributing to the spend, as well as some unpredictable or predictable spending related to pharmacy and other services.
Steve, how much of that billion is related to the HRIP, or is that already been factored in?
That's already been factored in.
Right.
It's some of that is related to the change in FMAT, as we alluded to earlier. But that would be not the grand total spend. It would be how much difference we pay in state funds versus federal.
What about Senate Bill 280, which you referenced earlier? Is that impacting this?
It is, yes. It's about $135 million in total.
Thank you. Representative Wilner?
Oh, my question's actually about Anthem, so I can hold that.
All right, thank you. We'll get back with you then. Senator Frankie Fromeyer?
Yes, thank you. The Division of Program Integrity What findings have been presented in 2024, in the fiscal year 2024?
As it relates to fraud, waste, and abuse?
Yes.
I don't have that information with me, but we'd be more than happy to go back and get reports and provide those to this committee.
In follow-up to that, I would like a more specific breakdown as you're describing increases in pharmaceuticals that could be more pricey. The very acutely unwell were already on the rolls. So increasing by $1 billion is astounding. And I'm also very concerned about what sort of wellness remedies are being prescribed versus drugs. And I'd like a breakdown of that. Thank you.
Senator Douglas.
Thank you, Mr. Chairman. Would you give me a little leeway just to ask 3 questions? I'll try to make them easy. Commissioner and Mr. Bechtel, the first question is, we do have a decreasing birth rate all across the world, all across the country. Do we expect to see a decrease in the number of enrollees in the Medicaid in this program as this trend actually starts to hit home? Has there been any thought in that space?
When we develop our budget, we do predict our enrollment trends based on current trend lines. And so I don't have those trend lines currently with me, but we'd definitely be more than happy to share those. We share those each time we develop our budget. And again, it's based on historical utilization.
Okay, but the question was, historically, we've always expected the population to go up. And so I'm trying to figure out whether we're still using those numbers, the historic utilization numbers that have traditionally gone up, or are we looking at the current trends of where our birth rates are going?
Steve, do you know when we develop?
I don't know specifically to birth rates, but for our eligibility forecast, we did forecast as we illustrated on another slide, we were within 0.45% of our eligibility estimates, basically. And that was, if you recall, we were given less than a month of data to come up with that projection with the redetermination starting in May, and then we had to turn around and have our have the budget submitted to you guys by October to LRC. So, we did for 26, we did, or 25, we did project a decrease, like I said, and we were really close. And we used that point forward in our trends. As you can see on this graph that's showing, you can see the big decrease. But you can see starting in June, starting July, we're starting to kind of level off. So it's around 1.45 million, 1,450,000 is where we're kind of been hovering for the last 4 or 5 months, give or take some.
Oh, thank you. May I, Mr. Chair, continue? Second question, one of the reasons we started covering more outpatient costs, or at least one of my understandings was the anticipation that it may decrease hospitalizations of this particular population. Are we now taking a look and saying costs are still going up? Are we saying that treating people in an outpatient fashion has helped, but it has decreased or slowed the rate of rise? I'm trying to correlate those two because that was one of the reasons that we were going to cover some of the outpatient was to decrease hospitalization and therefore decrease costs.
We do, as it relates to behavioral health services, we do have a slide where we talk about that, Senator Douglas. We are not seeing a huge decrease in hospitalizations at this time.
Question number 3, could you give me just a ballpark figure, and I don't know if this question has ever been asked, the average cost of an enrollee across the board in the Medicaid program?
We don't have that number with us.
Is there a way we can get that?
Yes, sir.
I think that number is incredibly important.
Yes, sir. We can get that number, and I think that you would want two numbers. You would want one for the managed care population and a different number for the fee-for-service population, because those two groups of individuals have very distinct and different medical needs. So I think
they do, but I would like both of those numbers, and then if you could, just some simple math, average everyone across the board. That would be very, very helpful, I think, to me and certainly the people on this committee.
We'll get that information
Thank
for
you very much. Thank you, Mr. Chair.
Senator Adams.
Thank you, Mr. Chairman. I have two questions, if that's okay. First of all, I think your presentation is really interesting because we, as members of the General Assembly, I mean, what this is showing is that we're expanding Medicaid, and then we are crabby because we're expanding Medicaid. And so I think these graphs are really indicative of what we're doing to the program just as much as what the program is unfolding. But that's just my comment. The first one is, I know there's been an uptick in name brand pharmaceuticals rather than the generic, which is costing a lot of these people money. And the cabinet receives the rebate on those since we've gone to a single PBM. What is the amount of the rebate that you all are receiving as a result of the single PBM? That required to go directly back into the program, or is it being used in other parts of cabinet expenditures?
I don't have the number directly impacted by the single PBM, but I can tell you the grand total of drug rebate that we received in fiscal year 24 was about 1.56 billion. So we had but most of that, let me just remind you all that it's not a revenue source. It's a offset of expenditures. So that when we build that in to our budget, we decrease the amount of general fund that we ask for because we're offsetting it with those drug rebates.
So it goes directly back into the program.
Correct.
It's not used in any other
No,
capacity.
Ma'am.
Okay.
And then I will say about 80% of that goes back to the federal government, and 20% is what is state funds.
Okay. And then my second question, Mr. Chairman, is the cabinet prohibits the use of prior authorization on behavioral health services. And there's been some consternation because providers are, some feel, are going unchecked. What is your all's plan to kind of deal with that behavioral health and the increase in expenditures around that area?
We do have prior authorizations on inpatient and residential behavioral health services. That's due to a CMS mandate regarding our currently approved 1115 waiver. We are having discussions related to prior authorizations as we move forward with behavioral health. The one thing we don't want to do is put up barriers for anyone needing that care, but through the presentation as I go forward, you'll see some of the information that we are talking about as it relates to behavioral health services and some of the things that we're thinking about.
Representative Duval.
Thank you, Mr. Chair. So we have approximately 1/3 of Kentuckians as recipients of Medicaid, according to the numbers. How does that percentage compare to our surrounding states?
It's very similar, particularly with states in the South. Some states have a little bit more enrollment, but it is very similar to our bordering states.
Representative Raymer.
Thank you. I think I probably speak for a lot of people on this committee. When we look at these numbers of how many in our state are on Medicaid, I think that's very concerning to me. One of the things I would like to see is what's the average length of time an enrollee stays on Medicaid. And I think we need to continue as a General Assembly to think about what we can do to help the people that need help, but then transition these people off of Medicaid and back into the workforce. And I'd also like to see a breakdown of the demographics of who is on Medicaid. You know, when we have able-bodied individuals that need to be in the workforce that are dependent on these government programs, it's a strain on resources, and we want to be able to help the people that need to help it. So if you all could get that information to us, I think it would be beneficial to this committee. Thank you.
We'll get that information. Thank you.
Representative Duval, just to follow up on your question, I was looking at the data just this weekend, and we are in the top 6 in the nation in terms of percentage of our population on Medicaid. And surprisingly, number 1 is California. But just a note there. Senator Berg?
Thank you, Mr. Chairman. Thank you, guys, for a complex presentation. Do we have any ability to monitor the efficiency of our MCOs? Do we know of all the money that we're, giving to them and flowing through them? What are they using as their administrative costs? What percentage of that money is actually going to direct patient care? Do we keep that type of data on them, or do we just trust them to be efficient?
We definitely keep that information on the managed care organizations. The current contract states that at least 90% of the funds that we give them have to be spent on direct patient care. So we do monitor. That's part of our medical loss ratio calculations that we use. In addition, beginning in 2025, we are entering into value-based payments with our managed care organizations. We, the department, will be withholding 2% of their total capitation payment. And in order to receive that 2%, they will have to meet certain quality measures, which we will monitor and keep track of as we go forward.
A follow-up, sir?
Yes, please.
Could we consider one of those monitors to be that you're actually covering services that the cabinet says you should be covering? Because I'm hearing from people all over that our MCOs are refusing to cover certain services that we have told them they should be covering.
Yes, they are contractually obligated to cover everything that the Department for Medicaid Services covers in our regulations. When you hear of those instances, if you can reach out to the department, we will investigate those and make sure that the MCOs are held accountable for delivering those services that are outlined in their contract.
Co-Chair Moser.
Thank you, Mr. Chair. Thank you for this presentation. I think there are so many questions that we all have. I really appreciate your being here. I like the discussion around outcomes and monitoring the MCOs. I think it's all of this will play into the data collection and our ability to really look at outcomes as far as what's working, what isn't, are there duplicative programs that we can phase out? I think that's probably something that you'll be working on with the new data informatics. But as far as monitoring the outcomes and enforcing the infractions or the MCO's lack of payment or following statute, what are the penalties, and how often does that actually happen?
That depends on the actual infraction. Sometimes we do corrective action plans. We can assess monetary penalties, but it just depends on the number and volume of the noncompliance with contract. We do have a section in our contract that specifically outlines what those penalties are. Be more than happy to send that section to you for review.
Okay. And if I may ask one more question, please. Tagging on to the discussion around how we best transition individuals from government assistance to private pay, we've had some conversations about benefit cliff modeling tools. And I'm wondering is this something that the cabinet is working on? Have you implemented any of the modeling tools that we've talked about in terms of stair-stepping individuals off of the benefits as they're able to take a raise, get a new job, exceed the salary limitations?
So Kentucky does have a really great integrated eligibility and enrollment system. Because our, and we call it our IEES, Integrated Eligibility Enrollment System, several states have actually asked for our source code and are using the same system that we use. Because we have a state-based exchange and we have all of our eligibility in one system, once an individual no longer qualifies for Medicaid, we can tell that they would qualify for a product on our state-based exchange, and we can help them transition to that exchange.
Okay, thank you.
Senator Carroll.
Thank you, Mr. Chairman. Commissioner Lee, can you kind of explain a little bit more on the quality metrics? Is that going to be healthcare outcomes or relations with providers? How is that going to work?
Well, specifically, we have certain quality measures such as number of immunizations. There are, and I don't know them right off the top of my head, but we do have a list of quality measures that each MCO will have to meet. Again, more than happy to send those to you, but it's going to be based on the health status of their members and how they're improving the health care of their members.
And one final question. Do you all track complaints on managed care organizations?
Yes, we do.
Okay. And is that published?
I don't know that if it's published yet, but we are evaluating some of the complaints that we receive. I can take that back and see if that's something that we would be able to publish, again, keeping in mind HIPAA violations and that sort of thing. So we'd have to look at and see what sort of information we have and how we could put that into a usable format.
Okay. And I've said this many times, I just wish we would get to the point where the managed care organizations and the providers, it's a true partnership and not an adversarial relationship. I do not hear anything good about MCOs in this state, and I'm sure it helps, financially. It does save money, but there are services denied. They don't want to pay providers, and it is the providers who are responsible for the health care outcomes, not the MCOs. Their role is to pay for the services rendered, and it's not just in my field. I hear everybody I talk to in this state that provides health care struggles with the MCOs. And we as a state, Medicaid, you all need to get a hold of that. And I know you try to tighten up the contracts. They don't pay any attention to you all. They just ignore it and they go on. And we have got to do something. And my hope is that Chair Meredith's bill someday comes to fruition and we get down to 3. If we can do it with 5, we can do it with 3. And that would save millions, if not billions of dollars for providers in not having to rebill and having to track down payments, send additional information, all the staffing that's involved in that. We just take money out of providers' pockets that they need to survive just trying to appease the MCOs. And I'll get off my soapbox on that, but it is an ongoing problem, and it just doesn't get any better. And I hope that you all at some point will really tighten down and really make them do the job they're supposed to do and look at the providers as partners and not someone that you're just squeezing and trying to avoid paying or delay paying. Thank you, Mr. Chairman.
Preach it, Senator. Preach it. To conclude this section, I just want to give some historical perspective to this. When I came to the Senate in 2017, I think we were covering 900,000 lives, and the budget was right at $10 billion. But the word of caution there is, as Mr. Bechtel has already mentioned, is we didn't have a lot of the directed payments we see today. So when we're trying to do a side-by-side comparison, it's very difficult to do. And again, I think this is where our Office of Health Data Analytics will help us. But we can't just assume that the cost has increased double during this 8-year period. But the increase is alarming. But appreciate the questions regarding that. Let's move back into the transition from the termination of Anthem's contract. And Commissioner, I'm sorry to interrupt you right in the middle of that, but I'm sure you can pick it up right where you left off. You're great at that.
Well, thank you. So we do have a timeline on the Anthem transition. We do have a reassignment plan. Currently, there are approximately 157,000 members enrolled in Anthem. Because we wanted to have sort of the same number of members, what we decided to do was split the existing Anthem members with the two MCOs that have the lowest number of member enrollment, which is Humana and United. That will result in an equal split in the following order of priority. If a household member has the same MCO, of course, that will take precedence. If they have a preferred provider in one of the networks, then that will also take precedence. Otherwise, it would just be auto assignment on a round robin fashion. Again, the reassignment has taken place on November 10th with an effective date of January 1st of 2025. With the reassignment plan, no new or current members will be assigned to Anthem as of November 9th. The reinstatements through December 31st of 2024, members may select or be auto-assigned effective January 2025. So basically what we have done, we have sent communication to our members telling them that Anthem will no longer be a Medicaid managed care organization. Between now and January 1st, they will have an opportunity to select any managed care organization they would like. If they do not select a managed care organization, they will be auto-assigned to United or Humana based on the algorithm that we previously showed. We have been doing several communications, both for our members and our providers. We have information on our platforms, on our websites. We have given information to our Medicaid Advisory Council as well as the various technical advisory committees. We have a dedicated phone number for Anthem members as well as a dedicated website, and we have developed a frequently asked questions document to help with any outstanding questions from either members or providers. There was a question, I believe, about the managed care organization contract. We have the current base contract is good for a period of January 1st, 2021, when we entered into that contract, through December 31st of this year. Due to the public health emergency, COVID, uncertainties around some of the legal issues, we have decided to elect a 2-year option to extend until December 31st of 2026 with the 5 remaining managed care organizations. Calendar year 2025 contract changes do focus on clarifying current requirements, adding language about our reentry, which you're going to hear a little bit about now, and the Consolidated Appropriations Act of 2023, which requires the Department for Medicaid Services to cover services for children enrolled in or in the custody of the Department for Juvenile Justice. We have talked just a little bit about behavioral health. I wanted to put this provider listing up here just to show the grand total of our behavioral health service organizations and our behavioral health multi-specialty group. The Department for Medicaid Services did not cover behavioral health services in broad fashion until 2014. Prior to that, it was mainly limited to the community mental health centers. We have expanded the array of behavioral health providers. And as you can see, there's 649 currently enrolled in just the Behavioral Health Multi-Specialty Group and the Behavioral Health Services Organization. This does not include providers who are individually enrolled such as psychiatrists, licensed family marriage counselors, and those sorts of things. So as we have talked, we have seen an increase in behavioral health enrollment for our providers. We have also seen an increase in behavioral health utilization. That is not unique to Kentucky. This is a conversation that is actually being held at the national level. Based on this utilization, some of the MCOs started doing some data analytics, looking at outcomes, quality measures, those sorts of things for those members who were receiving behavioral health services. They looked at such criteria as providers who were 3 standard deviations above their peers in billing, for example. Over 70% of providers who had non-clinical services rather than clinical services with outcomes no better than their peers. They also looked at readmissions and ER visits as they were continuing to increase. So not all providers, not all behavioral health providers met these outliers. There were about 60, I believe, providers who met this criteria. So some of the MCOs began rate contract and negotiations with those providers who met that criteria in order to ensure that the members receiving those services are really seeing outcomes. I think I can stop there. We're getting ready to get into our 11:15.
Yes, let's back up just a little bit because Representative Wilner had a question about the Anthem transition portion. And I think there may be a couple other questions as well. So please, Representative Wilner.
Thank you, Mr. Chairman. And first of all, Commissioner Lee, congratulations on your new position with the National Association. I love it when our Kentucky leaders are national leaders as well. So
Thank you.
So yeah, I do have a question about the Anthem transition, and I understand the Medicaid piece and all that you guys are doing so that people don't fall through the cracks. I have some concerns and some questions about the Anthem Medicaid patients who are also on Medicare through Anthem, and I would be really curious to know how you're ensuring that those folks don't lose their Anthem Medicare Advantage as part of this rollout from Medicaid.
So there is a contractual requirement that individuals who are dual eligible, they enroll in what we call a DSNP, a dual needs special population. There is a requirement that in order for a managed care organization to offer a DSNP, that they also have to be in Medicaid managed care. We have identified those individuals who are currently in the DSNP and are working to make sure that they are transitioned appropriately. Also, we have during our transition to other Medicaid members, we do have a listing of anyone who has special needs, for example, pregnant women, anyone who's in case management, to make sure there's a warm handoff to any other Medicaid managed care organization. And as we move forward with the DSNP, we'll make sure that those individuals are handled appropriately as well.
Could I just follow up? So just as a quick follow-up, so we've got this really detailed plan of how those Medicaid-only folks will be transitioned. Is it possible that we could see in writing the same level of detail about how these dual-eligible folks, we all have constituents who are going to be affected by this. We're all going to be hearing from them if January comes and they think they have their Medicare plan, advantage, and they don't. So I think that this is a brewing problem that could be prevented, and could we be given some reassurance that that'll be dealt with?
Yes, we will take that back, and also the dual eligibles or those that are in a Medicare Advantage plan. They're governed by Medicare, so we'll get some more information and put it in our transition plan and get that to you.
Thank you very much.
Got a couple of questions for you on the reassignment. I understand your logic there, but then again, I don't understand the logic. We get an argument a lot of times about wanting a free market in healthcare, which my counter is there is no free market in healthcare, but there is specific insurance coverage. And we've got 5 providers. So I'm just curious as to why Humana and United enrollment is so much less than the other 3. Do you know?
No, I don't know. I mean, every Medicaid member has an opportunity to select whichever managed care organization they choose, and I'm not sure why one Medicaid member would choose one MCO over another.
Well, wouldn't that be something that we would want to take a look at if the other 3 are more client-oriented, a little bit consumer-friendlier? Offer maybe some tangibles that the other 2 don't? Shouldn't that be impactful in making these decisions as to who gets what?
We can go back and take a look at that.
I think it would warrant at least trying to understand why there's a difference. I'd like to some thought into that. Another is the contract itself, and I understand you're wanting to extend us even further, but 2021 is a lifetime ago in healthcare, and there's a lot of changes that I'm very concerned that may not be in the current contract. Most notable is the use of artificial intelligence. Does the current contract have sufficient safeguards in place to protect our Commonwealth and our constituents from intrusive AI practices. And specifically, I read an article just this last week that more and more insurance companies rely on this for pre-authorization purposes. And what they're building into the formula is, if they're losing money on a particular product, then they will automatically reject 10% of all pre-authorization to be appealed. If things are really difficult, then they'll do 20%. So do we have safeguards in place to protect us in that particular scenario?
I'd have to go back and review the contract for that specific language.
Well, I think this is a big, big issue that we need to give some consideration to, because, again, a lot has changed since 2021, and I'm not confident that we've got the safeguards in place to protect us the way that we should. But Senator Carroll?
Thank you, Mr. Chairman. And I found out recently that the MCOs, there's software packages that they use. People enter data into these systems, and it spits out what's medically necessary. And in our case, as far as therapies, we had an issue with one particular MCO. They stopped approving therapies for kids that, without question, needed them, and they were going to need them probably for the rest of their life. And if I understand correctly, what happened, they went to a new system, and the system was making their assessments based on rehabilitation rather than habilitation. And to this MCO's credit, they backed up and admitted that they made a mistake, and they're fixing that. But I think that is, like you just said, in one way that probably AI is going to be used more and more in systems like this as we go. One question about Anthem, the contractual obligations that they currently have, is the cabinet going to monitor to make sure that every issue that they have with providers, that those are resolved before they are released of their obligations?
Yes, that is in our transition plan. So we do have plans in place to monitor activities, claims payment, claims run out, that sort of thing, provider complaints as we go forward with the transition, and it does extend beyond January 1st of 2025.
Okay, thank you. Thank you, Mr. Chairman.
Senator Douglas?
Thank you, Mr. Chairman. I do want to follow up on one thing that the chairman had talked about, and that is why there is a disproportion of people enrolled in one versus the other. Personal and professional experience. Part of that is that the patients talk to each other and they complain to their healthcare providers, and it's just too much of a hassle. So they leave. They know which ones are out there that may make it easier for them to receive their care and be able to see their provider and get their needs met. And I agree, Mr. Chair, we really, really do need to take a look at this, because from a provider standpoint, it's killing the patients. It's killing the patients. My questions, however, when you talk about we extended the contract for the MCOs from to 12/26, could you help us and everybody watching? Who is we?
That is the Cabinet for Health and Family Services. This is not a decision that was made.
Including who? I know, but
it's the leadership at the Cabinet for Health and Family Services.
Okay, I just think that's important. The second thing I want to ask is on page 8. We looked at 70% of billing was non-clinical, that kind of thing. Outcomes were no better than peers. Could you help me understand how those outcomes were assessed and compared?
I would have to get additional information from the specific managed care organization, but it's my understanding that those individuals were continue to go to the ER at a higher utilization rate, and that the members also had extensive or more costly health care than members that were being treated by some of the peers.
That's really interesting, because when I talk to my colleagues in the healthcare space, they have a totally different view of that whole situation. I want you to know I really, really appreciate you guys being here. You guys take some tough questions. I really, really appreciate that. Thank you, Mr. Chair.
Co-Chair Moser.
My question's about behavioral health. Do you want me to wait?
Yes, please. Yeah, we could. We'll get you those. Representative Rourke. Okay, thank you. Senator Berg.
Thank you, Mr. Chairman. And this is a follow-up to the statement that Senator Meredith made. We are seeing all over the country reports of AI being used on its own without any human supervision to deny as part of prior authorizations. And I think it is very important that we as a body and you all as the people that overview these MCOs, that we require as a state that every denial goes through human eyes before it goes to the patient. Because these are extremely disruptive for families, even if it gets fixed. Even if 2 weeks later you find out, oh yeah, we're eligible. Those 2 weeks are horrible 2 weeks where you need something and your insurance company is telling you you can't have it because they think you don't need it. That needs to go through human eyes and not just, artificial intelligence to make those decisions before they go out. And if that is not part of our contract, I would beg us to make sure that it becomes part of our contracts.
Another thing that influences this is, I don't know if we had any committee members that were on the AI task force this summer, but obviously it's all data driven, and that the experts said there's as much as a 35% error rate in terms of cultural biases, misinformation. So that's significant, something to look at. But any other questions specific to this Anthem situation? If not, are any questions regarding the behavioral health provider enrollment? Representative Rourke.
Thank you, Chair. And Commissioner, I wanted to ask a little bit more about maybe relating to that over 70% of billing was non-clinical. Does that have to do with the inpatient versus outpatient billings and things like peer support specialist? And are you seeing a difference in the rate that is being paid to peer support specialists as opposed to a clinical specialist when it comes to behavioral health?
Yes, the non-clinical is related to peer support specialists, for example, psychoeducation. And peer support specialists do receive a lower reimbursement rate. I would like the committee to know that recently the Cabinet for Health and Family Services leadership, as well as members of the provider community and the managed care organizations, did collaborate, talk about some of the behavioral health issues that we're seeing. We did draft a policy clarification related to some of those non-clinical services. It has been distributed to our Medicaid providers. So again, that was done in collaboration with the MCOs, the provider representatives, and the cabinet leadership to address some of the concerns that we were seeing with the billing of non-clinical services.
Wanted to ask one follow-up. Are you hearing concerns from the managed care organizations about holes in their budgets related to behavioral health services?
Well, being president of the National Association of Medicaid Directors, I see this on a national level. There are concerns and talks with the Centers for Medicare and Medicaid Services at the national level, and managed care organizations across the country are talking about the increase in behavioral health and pharmacy spend and the impact it has on their rate development.
And then just finally, did that have anything to do with Anthem's termination of being an MCO?
No, that does not have anything to do with Anthem's termination.
Co-Chair Moser.
Thank you, Mr. Chairman. Thank you for this discussion. I've heard from many providers about the issues with the MCOs, and specifically as it relates to addiction treatment. A little comment or observation maybe on my part. I think that we have a real life example of having no CON in this area and no guardrails around who comes into Kentucky. We do have certainly standards of care that individual treatment providers are required to meet. I don't know how we're ever seeing this with the really explosion and influx of these treatment providers. People who are just setting up shop in abandoned storefronts and slapping their name on it, and I don't know what kind of care they're delivering. I'm hearing that it's questionable. We did talk about and passed a law last year to control the folks who are recruiting from out of state and enrolling individuals in Medicaid. But I still think that it all comes down to maybe the criteria. Maybe we need to take a look at the criteria again, the standards of care. We passed a bill, House Bill 124, back in 2018, I think, to set some standards of care around addiction treatment. Do we need to look at that again? Do we need to look at credentialing? Because, obviously, CON it's not a popular time to add that guardrail right now around this particular treatment modality, but we need something. And I see that this is potentially part of the explosion in our Medicaid billing for this area. Do we need to take a better look at credentialing? Credentialing is really where we have the ability to look at those providers and whether or not they're meeting the criteria. So I think that something needs to happen around this space, and I know that you're working on it. So that's my commentary, maybe about what's happening there. I do have a couple of questions about the psychoeducation. I know that Kentucky is the only state who uses this H2027 billing code. I'm curious about what the rationale was for that, who can use the code, and how much has been paid out in using the psychoeducation code in the past year.
I don't have the dollar figure, can definitely get that, but that code was added to the behavioral health fee schedule in 2016, so I'm not sure what the rationale was when that code was added. And previously, the Department for Medicaid Services had two fee schedules. We had an inpatient behavioral health or facility. We called it a facility behavioral health and a non-facility. The code was on both fee schedules. There was a little bit of a difference in the reimbursement amounts for those. There was some confusion related to providers on which fee schedule they could actually bill off of. So in 2023, we combined those fee schedules and we took the higher of each code and put it on the current fee schedule because we did not want providers to receive a reduction in reimbursement. And so since 2023 is when we have seen an increase in the use of H2027. The provider guidance that we just developed that was sent to providers earlier this month, excuse me, it contains information about billing for H2027, who can bill for it. It contains the rates. We will continue to monitor that. We believe this is a first step to make sure that, again, individuals, our Medicaid members, are receiving the appropriate services at the appropriate time at the appropriate location. Because our focus is definitely on our members. We don't want to create barriers, but we do want to monitor and make sure they receive appropriate services. That guidance is out on our website. I'd be happy to send that guidance to you, Representative Moser. It may help answer some of your questions.
Okay, thank you.
Thank you. Don't see any more questions, comments. We could, I'm sorry, Senator Carroll.
Thank you, Mr. Chairman. Commissioner, I personally, in the organization that I run, we have just started dealing with private insurance, and that's a whole nother level of frustration from the MCOs. And I know you can't make them pay certain rates, but do you all look at that as far as providers throughout the state? It's a balance, and it's a balance with the number of Medicaid kids that you bring and the number of private insurance, and with the private insurers, there's really no no rules. They pay what they want to pay, and in some cases, certain codes are less than Medicaid rates. So what, just in general, how do you all look at the private market, and when you look at, with Medicaid rates and where we are as a state, what does that discussion look like? And do you feel like in the private arena, is there, should we be putting more parameters on the private sector as far as the rates that they pay and requiring them to work closer with providers and be more equitable with rates and that type of thing?
So the only thing that Medicaid compare our rates to is Medicare, because that's nationally published. Rates for commercial carriers are typically proprietary, and we don't have access to that information. Our focus continues to be making sure that our members receive the appropriate services that they need in order to improve their health. We do contract with our managed care organizations. We do not enter into interject ourselves into their negotiations with their providers and their negotiated rates. So again, the only thing that we can compare Medicaid to is the Medicare rates that are nationally published.
And I will just add on to that we have upper payment limits that we have to meet within Medicare. So all of our fee-for-service rates on our fee schedules, we have to be below the upper payment limit, which is the Medicare rate.
Last question on this topic from Senator Berg.
Thank you again, Mr. Chairman. And this is an honest question. I really do not know. The influx of private equity into the healthcare system, has that started to involve Medicaid providers? Representative Mosier was talking about how do we assure that we have quality in our state, and historically we did that by making sure that you had providers that were adequately trained, that were doing what they were supposed to do. But now, with private equity, a lot of the time the providers no longer really get a choice in the system that they're working in, because they're honestly being told what to do, what to bill, and how to do it. Is that influencing Medicaid payments yet? And are we keeping an actual eye out for those systems that are coming in intentionally to try to make money in spaces where the providers themselves have not been able to do it? Does that question make sense?
But I do not know the answer to that question. And I don't
so we're
know.
not even looking.
Well, I will say that all of the directed payments that I talked about, they have a quality measurement that those providers have to meet. There's a portion of that payment that they have to meet certain quality measures in order to get that payment.
The providers,
Yes.
When you talk about providers, you're talking about
hospitals, ambulance,
the systems itself. They
Right.
have to meet it. So, as far as you're aware, private equity hasn't infiltrated that market yet.
I'm not aware.
I'm not aware.
Okay, thank you. Thank you.
Well, related to that, Senator Berg, I think there's some concern about vertical integration from insurance companies as well, and does that give them an unfair advantage in terms of competition? And that's one of those contractual issues I think we've got to give some consideration to. Here's how we're going to finish up, folks. We still got 4 important topics we need to talk with. I'm going to let Commissioner Lee go through her presentation in total. Then we'll come back, and what time is left we'll use for questions for each of these subjects. So, Commissioner Lee, if you would, please continue.
And now we'll turn this over to Angela Sparrow to talk about our 1115 waiver.
Thank you, Commissioner. Again, we can see there are several projects under the overall Team Kentucky 1115 demonstration, and so we want to go through some of those today with you. Kentucky's reentry section 1115 again was approved in July of 2024 this year. We'll talk a little bit more in detail about that next. We also again have the substance use disorder demonstration, or the SUD 1115 demonstration, and it was first approved in 2018 and was implemented in 2019. We are again anticipating an extension of this demonstration that's pending with CMS. And so again, the components that we talk about, you can see are the ones that have been approved are currently approved through the end of this year. And then those that are pending, we anticipate a pending and extension of all components of January 2025. The SUD 1115 again allows reimbursement up to a statewide average length of stay of 30 days for our SUD residential treatment services. It also again waives the Institution for Mental Disease or IMD exclusion. So this allows reimbursement beyond 16 beds in a facility up to 96 beds for programs that meet qualifications and standards that are required under the demonstration and our milestones. With the initial 1115 approval in 2018, Kentucky was also approved to extend the Medicaid eligibility of our former foster care youth who are age 18 to 26, and for those that were former foster care under the responsibility of another state. So this extension is also pending with CMS, and again, hopeful by the end of the year. As a companion of the 1915I State Plan Amendment, which we'll talk a little bit more about, in May of 2023, Kentucky did submit a request for a serious mental illness SMI Section 1115 demonstration. And so this will allow for reimbursement up to a statewide average length of stay of 30 days for inpatient treatment for adults with serious mental illness, whereas right now, again, currently we can only reimburse for short-term stays in our inpatient hospitals, and again, short-term is defined as 15 days. With the May 2023 amendment, we also again did include a request to pilot a recuperative care service, and this is also known as medical respite. And so Kentucky again has requested the authority to be able to reimburse for a recuperative care service, and this is for adult beneficiaries who are homeless or at risk of homelessness that require additional medical support and care coordination following a hospital stay. And then another and our last, again, kind of pending request under the Team Kentucky 1115 includes Recovery Resident Support Service, or RRSS. And so DMS has requested the authority to be able to reimburse up to 90 days for the Recovery Resident Support Service for eligible adults with an SUD that are transitioning to the community under our reentry demonstration or participating in Kentucky Senate Bill 90, the Behavioral Health Conditional Dismissal Program. And so as a reminder, again, Kentucky is not requesting for this service to reimburse for housing, but again, this request is for developing the service that can be provided by recovery residents that meets our established standards and criteria. And again, hopeful to be able to receive this approval with the other approvals in January. Next slide. So to talk about a little bit about the Reentry 1115 project, again, I think we're all aware that our justice-involved individuals, again, do face disproportionate challenges and barriers upon reentry. Kentucky, we again continue to make strides in reducing incarceration rates and address the challenges for our reentry population. And we're excited again to be able to receive this approval. And this is a new opportunity that allows state Medicaid agencies to be able to reimburse for short-term targeted services prior to release. The project does again enhance and better streamline the reentry process, and we again hope to improve the care coordination between system collaborations and ensure that there's that continuity of care and linking the individuals to their medical and behavioral health services upon release. Again, we do want to provide a reminder that CMS did make it clear to states that with this opportunity, it is not intended to supplant the work of our correctional partners, but really, again, to ensure that our states are collaborating with our justice partners, with our medical providers, with our community partners, and our healthcare systems. But then again, that we are really promoting and ensuring that there's that continuity of care to support that individual through this transition period. We can go back, sorry. Thank you. So again, under the 1115 project, just to go through who the eligible populations covered services are. So this again is for all adults in our state prisons, in our Kentucky state prisons, and all of our youth and our youth development centers. They are eligible to receive the approved services. The covered pre-release services do include case management, so really there's the emphasis on the case management service to support that transitional period. So case management will address the physical health, behavioral health, and those health-related social needs. So what are the employment needs, housing needs, food needs, transportation needs, child care needs for that individual as they're released. And so again, this will begin 60 days pre-release, and I should rephrase that. So again, our correctional partners are already supporting reentry services at the time an individual again is incarcerated. This again can be a Medicaid reimbursed service at 60 days prior to release. And really again, the emphasis on our healthcare system and our judicial systems working together to identify those needs, and then again being able to develop that comprehensive assessment and that plan to meet those needs and how that will be addressed and carried out upon release. This also again, at release, the individual will be eligible to receive the case management services up to 12 months post-release. So again, ensuring that there's that continued follow-up and support available through that transitional period. As a requirement, again, of Kentucky's participation in the demonstration and through the approval, the package does also include medication-assisted treatment. So the MAT service, again, is reimbursement for the medication plus the accompanying therapies and counseling. And again, this can be 60 days prior to release. Our correctional partners, again, in DOC, Department for Corrections, there are services already available. This, again, will be able to expand, enhance, and again, be Medicaid reimbursable at 60 days. And so this, again, is for individuals with substance use disorder. And then also the package and approved services does include the 30-day supply of medications. And this is, again, all medications that's clinically appropriate at the time that they are released. Next slide. So we also do want to talk about, in addition to the Reentry 1115, Kentucky is also planning for new provisions under the Section 5121 and 5122 of the 2023 Consolidations Appropriations Act. And this, again, is amending existing laws regarding Medicaid and CHIP coverage for incarcerated individuals and placed youth. So do want to note that Section 5121 is mandatory for all states. Under this section, it does require coverage for selected state plan covered services pre-release. So again, these will be state plan covered services. The services under the 1115 demonstration are just demonstration. They're not included in the state plan. The Section 5122 is optional, and states can elect to participate in this optional section at any time. So do you want to go through what the eligible population under Section 5121 is? And this, again, is going to be for our adjudicated juveniles. So again, there has been a sentencing, a disposition, and this is for our adjudicated juveniles under 21 years of age or between ages of 18 and 26 and our former foster care youth. And under Section 5121, the covered services, again, are going to include our EPSDT services, so early and periodic screening, diagnostic, and treatment services. Do want to note that it will include screening and diagnostic services, and this will include for medical, dental, behavioral health, vision, hearing. This, again, is to be provided and can be provided 30 days prior to release. And then we also include targeted case management services available 30 days pre-release and 30 days post-release. Again, very similar to what we mentioned under the 1115, identifying what are those medical, behavioral health, and health-related social needs of the juvenile pre-release, and again, ensuring that they have those supports and that plan in place to be carried through upon release. And then do want to talk a little bit about Section 5122, the optional section. So the difference here for 5122 is that this does apply for pre-adjudicated juveniles. So again, there has not been a sentencing, has not been a determination. And again, for any individual under the age of 21 or between 18 and 26 in the former foster care. And here again, eligibility is not suspended at the time that that individual is incarcerated or placed in a correctional facility. And so this again means that the individual is entitled to the benefits included under the approved service package that they are qualified for. So under Section 5122, again, this does allow states to request that full range of Medicaid and CHIP services for the individual that they would be eligible for. So when we think about the definition of the eligible juvenile and where they could be placed in a correctional facility, or again, in a detention center, this does include youth development centers. This does include our youth detention centers. This does include state prisons and our local jails. Do want to note, again, that states did not receive direct guidance from CMS until July of this year regarding the CAA provisions. This, again, does create challenges and it does create barriers for states. States and CMS have had ongoing communication about this. And again, the provisions do take effect January 1st of 2025. Kentucky does plan to have a state plan amendment submitted to CMS by January 1st, and that is if they have the appropriate tools for us to do so. So again, the states are really still waiting for additional guidance and for the full information from CMS as they continue to develop that. So we again do plan to have that in place, given CMS has that in place for states. And we will have our operational plan in place by January 1st of 2025. And so again, through that, we will continue to develop what kind of the implementation timeline schedule looks like through 2025 for Kentucky to be in compliance with these provisions. Next slide. So in terms of the reentry project timeline, do also want to mention for the 1115, for the reentry 1115, though Kentucky did receive approval from CMS in July, there are several deliverables and steps that we have to take before we can actually implement. So with that, we have submitted our implementation plan to CMS the end of October. We do have monitoring protocols, a monitoring plan due to CMS the end of this month, and so that will be submitted the end of November. We do have evaluation designs where we need to, that is an independent evaluator that will monitor and evaluate Kentucky's progress, and again, be able to provide feedback, but how are we meeting our goals and our milestones? That evaluation design and our reinvestment plan is due to CMS the end of December. And then at that time, again, we'll continue discussion with CMS around implementation planning. We'll continue to work with DOC and DJJ, Department for Juvenile Justice, again, in how to operationalize the plan. We will continue that work through this quarter. And again, first quarter of January 2025. Then we will have facility readiness. We'll have system changes, things that we'll need to have in place once we get approval from CMS to be able to implement. So we can see here, again, the targeted date for implementation is October 1st of 2025. And then we, as mentioned, the CAA provisions, youth provisions will take effect January 1st, 2025, and we will work through 2025 again regarding the rollout of those provisions. Next slide. So we did mention earlier that the SMI 1115 demonstration again is a companion to 1915I State Plan Amendment. And so as we talked, again, this will allow additional reimbursement for inpatient stays for individuals with severe mental illness. And then again, we touched on the recuperative care pilot program. Next slide, please. Kentucky did submit the 1915I State Plan Amendment request to CMS in April of this year. Again, 1915Is do allow beneficiaries to receive services in their own homes and communities. So we are talking about home and community-based services instead of institutional settings. And this gives, again, the flexibility to cover HCBS services without a waiver from CMS. And so 1915Is again target a specific population and again does establish needs-based criteria for individuals to be able to receive the services. We can see here again that Kentucky has proposed an array of services that will include, again, several housing opportunities, housing supports, all the way from supervised residential care to in-home independent living. So we can think about more of wraparound services for individuals with SMI to remain in their homes. And again, tenancy support. So tenancy support services are more of those pre-tenancy, helping individuals apply for housing, and again, be able to sustain, to be able to secure permanent supported housing. And then again, those post-tenancy supports is being able to sustain housing. We also did include and ask for supported education, supported employment, assistive technology, so things again to support individuals in their homes, medication reminders, etc. Transportation is different than what is currently covered through non-emergency medical transportation. So this could be transportation to jobs, transportation for groceries, to other additional appointments that they may need. So this is outside of the non-emergency medical transportation benefit, as well as, again, the planned respite service for caregivers. So this, again, would be for individuals that are caring for SMI individuals, again, to be able to provide that relief and support that they need. So again, it is the services here, again, the transportation and medication management. So these services, again, will be different than those that are approved under the state plan. And also to note, individuals that would qualify for these services will still qualify for their full state plan Medicaid benefit services that they're eligible for. So these would be in addition to those services that they would currently receive today. Next slide, please.
So regarding our 1915C home and community-based waivers, we over the past few years have entered into a rate study for those services delivered in our 1915C home and community-based waivers. That rate study and methodology was submitted to LRC earlier this year. And so based on that rate study, there are several policy changes that are coming up. We have 6 1915C waivers. We have submitted those to the Centers for Medicare and Medicaid Services for review. Those amendments do contain the new rates that were developed as part of the rate study methodology. The new rate methodology took into consideration several factors, including legislative mandates, budgetary considerations, and the final result is that no 1915C home and community-based waiver will receive a reduction in any reimbursement. There are some codes that are going to be increased as we move forward. The waiver amendments, again, have been submitted to the Centers for Medicare and Medicaid Services. We received a total of 217 public comments on those waivers. We have a proposed effective date of January 1st, 2025, but that will be contingent upon CMS approval of those waivers. Upcoming policy initiatives, again, we have 6 waivers. Those waivers all have their own regulation currently, and so what we are doing is breaking out some of those regulations. For example, eligibility is not the same for each waiver, so we want to make it clear where individuals can go and get information, for example, related to participant-directed services. Rather than having 6 different waivers with inconsistencies, we will now have a few more regulations that will be a little bit easier for individuals to go and navigate when they want to look at policies and specific coverage of services under our 1915C waivers. This shows you the slot allocation, how many slots we have in each waiver currently. You can see that we had new slots added in 2025. We had a total of 650 slots added in 2025. Those slots can and are currently being allocated. The slots that are listed for 2026 are in our pending application waiver amendments, so will be added and be available as soon as those applications are approved. So you can see we'll have a total of 35,537 slots across all waivers. We do have a waiting list. Currently, we have 12,847 individuals on our waiting list. Those waiting lists are mainly for Michelle P. and our HCBS, which is our Home and Community-Based Services waiver. We have more than 1,758 of those individuals are on more than one wait list, meaning that they could be on a wait list for Michelle P. or for SCL or HCB at the same time. Of the total 12,847 individuals on a wait list, 88% of those have access to Medicaid services. So that means they currently qualify for Medicaid. The services that they will not be receiving while they're on that waiting list are those personal support services. They also cannot access participant-directed services. Participant-directed services are services where individuals themselves can receive their funding based on their level of care. They could receive funding to hire their own providers. For example, they may have a friend or a relative that could deliver those personal support services in their home. Also, if children are on the waiver and they are enrolled in Medicaid, they can receive a wider range of services through our early periodic screening, diagnostic, and treatment benefit, which we'll talk about a little bit more later. And children who are on the waiting list, eligibility for 1915C home and community-based waivers is based on the individual income. So there could be children who are on our wait list who don't qualify for Medicaid, but they will qualify for a waiver based on their income because typically children do not have income. So the Medicaid eligibility is based and determined on a total family income, parental income. Eligibility for home and community-based waivers, again, based on individual income. So there could be children who are on the waiting list who do not have access to Medicaid services. But the average number of weeks an individual is on our wait list is 171, and the average age is 25.5 years old. We have, according to some directions, we have developed a waitlist management assessment recommendations. Again, a report has been developed and submitted to LRC. We are going to align our waitlist administrative regulations across waivers. It's a little bit about what I touched on before, making sure that we have regulations that are clear and concise that individuals can go to for reference for services and reimbursements in our 1915C waivers. We're going to standardize our waiver application and eligibility review process. Of course, you can see that these dates we have started some of this activity, but most of this will not be finished until 2026, such as modernizing our waitlist management data collection system. We are developing a waitlist management dashboard that we can put online for individuals to access and monitor as we move forward. We also have been, I think it was House Bill 6, or the House Bill 6, to develop a child-specific waiver beginning in state fiscal year 2026. We have begun working on that child-specific waiver, for example, conducting system assessments, mapping out our array of services, gathering documents, identifying stakeholders. We are developing a communication plan, and we'll have an advisory work group beginning in January of 2025. Another topic on the agenda was a network adequacy report that the University of Kentucky research project is conducting. The Department for Medicaid Services enters into contracts with their state universities. We call them state university partnerships. Those projects are typically 2 years. They take into consideration various topics such as quality, access, such as this one, and just a variety of maternal child health, anything that we think could help drive policy in the Medicaid program. So in the 2024 was the first phase of this project. There was a little bit of an issue getting that contract finalized. So the work was only for 1 year. There was also some delays in getting data and developing metrics. So the university now has data. They have begun geocoding that information, and we have a 2026 continuation project with them, and we will be receiving reports, interim reports that we will be more than happy to share with this committee based on some of their initial findings related to the access, network adequacy. Well, forgive me today, I don't know what it is. Network access of our managed care organizations. Let's do it that way. And then there was a question about long-term care. Why does it take 30 days to determine long-term care eligibility? I'm not sure where that 30-day time frame came from, but it does not take 30 days. Sometimes it can take a lot longer than 30 days to determine long-term care eligibility for individuals in a nursing facility. Long-term care eligibility is one of the most complex eligibility determinations that you can imagine, because not only does it take into account the individual's income, there's assets that are taken into consideration. If an individual has a trust, life insurance policies, those same things have to be investigated. We do have an electronic method of determining eligibility, and it's called the Kentucky Level of Care, or CLOCS. So if an individual is determined eligible, they do have to meet level of care for nursing facility. It can be, and it does, is retroactive. The Medicare only covers about 20 days in a nursing facility. So again, the whole reason for the length of time it takes to determine long-term care eligibility is we need to make sure that individual does meet that level of care for a nursing facility stay. Sometimes we may have some individuals who are enrolled in a Medicaid managed care organization who need nursing facility level of care, maybe for rehab or something like that. Those managed care organizations are responsible for providing that care. If they're in there for less than 30 days, the MCO will pay for that. If the individual is transferred to fee-for-service, then Medicaid is billed directly, and the MCOs may be responsible for some cost. If an individual is already enrolled in Medicaid, let's say they're in our fee-for-service program, they may be in a home and community-based waiver, they still have to meet level of care for Medicaid to reimburse that nursing facility, and sometimes they may move from a home and community-based waiver into a long-term care facility. So again, it does not, there's no rule, federal or state, that a person has to be in a nursing facility for 30 days before they can determine Medicaid eligibility. I think one of our next topics is the early and periodic screening, diagnostic, and treatment benefit, which is EPSTT. This is a benefit specifically for children under the age of 21. And basically what this benefit says is a child should receive any service that is medically necessary, whether or not it's covered under the Medicaid state plan. The one example that I always give that helps a little bit is that Medicaid has a limit of 2 dental cleanings per year, for example, for children. In the event that we have a child with special needs, that limit of 2 has to be overridden in order to give them those medically necessary services. The same thing with any service that has a limitation on it, or any service that we may have decided not to elect as a mandatory benefit in the Medicaid program, because the Medicaid state plan has optional and mandatory benefits. A lot of people don't know that pharmacy is an optional benefit. It's optional in theory. It's not optional in practice, because without medications, individuals are not able to improve their health and to maintain their health. So some of those services that are considered optional are not optional for anyone under the age of 21. Earlier this year, CMS, the Centers for Medicare and Medicaid Services, submitted or delivered guidance related to the EPSDT benefit to make sure all states are in compliance with the service array and the outlined in the guidance. And again, just stated that all children and youth under 21 are entitled to all medically necessary services to prevent, diagnose, and treat services that are covered by Medicaid. And this includes any services that are optional or that are provided to adults. They have to be provided to children. The rest of the EPSDT guidance it talked about strategies to meet the behavioral health needs of children and youth. Again, behavioral health issues are not unique to Kentucky. They other state Medicaid agencies and even outside of Medicaid are experiencing issues with behavioral health access, specifically for children with high acuity needs. So CMS has released this guidance to make sure that states can meet any of their obligations and that they are meeting obligations related to EPSDT. So if a provider network can't provide the services, the contractor or the managed care organization in this case must cover them out of network at no cost to the beneficiary. So again, EPSDT benefit for children under 21 that basically states that children should receive any medical service they need, not only to treat their current condition, but to prevent that condition from worsening in going forward. And with that, we'd be happy to take any additional questions.
And you've done an excellent job, and wealth of information we received today, and certainly appreciate it. We've got about 10 minutes for questions, and we have several. We'll cut it off right at noon because we have other committee meetings, but please keep your questions short and your answers shorter. First is Representative Fraser Gordon.
Hi, thank you for being here. I have a question in regards to the 1115 reentry project. So I also serve on the administrative regulation. And the regulation ended up being deferred, but there was a regulation that would prohibit, I guess we have currently a prohibition about felons receiving SNAP benefits, and that administrative regulation was going to remove that. Was that for the purposes of this project, and was it just for people in this project, or is it for all felons?
Specifically to the SNAP benefits? May have to take that back. I'm not sure that is, again, it's not a component under the 1115. So we can take that back and look into that.
Thank you.
Mm-hmm.
Representative Wilner.
Thank you, Mr. Chairman. You guys have been busy. I want to commend you for making pre-adjudicated youth are no longer in a medical limbo situation, so that's really good news. I wanted to follow up about the waiver wait list management, and one of the things that I understand is people don't find out if they're eligible until they get to the front of the list, right? And so they could be in that list of tens of thousands of people for years, and then they finally get to the top and it's like, oh, you're not eligible. Is there anything being done so that people can find out if they're eligible prior to getting to the front of the line?
So some of the work that we're going to be doing on modernizing the waitlist management collection, again, going back and creating a dashboard to make sure that individuals, stakeholders, that they know. And if you look at number 2 here, we're going to standardize our waiver application and eligibility review process to enhance our waitlist information gathering. Currently, there's not a lot of information that's gathered for an individual to go on a wait list. Some individuals may want to be placed on a wait list simply because they know they may need those services in the future. So what we want to do is gather more information to make sure that those individuals on the wait list would actually qualify once they are eligible to receive a slot. But again, knowing that an individual's health status does change periodically, that initial eligibility and information gathering would have to be conducted, more routinely to make sure that any individual on a wait list maintains the current level of their current health status would continue to meet the level of care for that waiver going forward.
Representative Rourke.
Okay. I also have some questions about wait. Do we have the current numbers of wait lists broken down by each 1915C waiver?
Yes, we do. We can get that information for you.
Thank you. And are we on track to resolve the waiver wait list within the 8 timeline, or does it actually look like it's a little bit longer than that?
I don't really have an answer to that question right now, but I can take that back and see, based on our current wait list management assessment and activities going forward, if we believe that we would be able to solve that within the 8-year time frame.
And then lastly, just what is being done by the cabinet for person-directed services, particularly in Jefferson County, with the wait list due to the lack of support brokers and case managers for, let's say, the ABI clients?
Yes. So the department coordinates participant-directed services with the Department for Aging and Independent Living. They oversee those activities, and we have been working in collaboration to identify those areas where PDS has been not administered timely, or there have not been enough support brokers to administer that. So we are working with the Department for Aging and Independent Living, which is a great partner in all of this. So we are working with them to identify those gaps and create some workarounds, if you will, until we can actually actually find the support brokers that are needed to oversee all of those case managers who are overseeing the participant-directed services.
Thank you.
Representative Neighbors.
I'd like to go back to the topic of the long-term care 30-day eligibility. So what I'm hearing is that the biggest issue that some long-term care providers are facing right now is the rule that you must be in the building for 30 days prior to Medicaid becoming effective. So for example, a resident enters a nursing facility on October the 1st and immediately makes application for Medicaid. The resident then discharges, say, on October the 26th. Either they go home or they pass away. Medicaid closes the application process due to not meeting the 30-day rule, and the individual is denied benefits without determining whether there was financial qualification or not. So is that a state rule or is that a federal rule? And is there anything that we can do to change that if it's a state rule? What recourse do long-term care providers have in that situation where the resident is in the building for less than 30 days and obviously is looking to receive payment for the care that was provided?
Well, each case is definitely unique, and would be more than happy to research any of those. I don't know of the 30-day rule, given your specific example. Representative Neighbors, I can go back, get some more information for you related to that specific example as to what could be done. If that individual, it could be that individual qualified for Medicaid, then that stay should be paid. If they haven't been determined eligible for Medicaid, if their resources and their assets, for example, are too much, and they are not determined eligible for Medicaid, that stay would not be paid. But I can definitely get more information for you on that. I don't know of a federal rule or a state rule that says an individual has to be in a long-term care facility for 30 days.
Okay. Thank you. I would appreciate that.
Final question from Senator Carroll.
Thank you, Mr. Chairman. Commissioner, on the number of individuals on the waiting list, did you say how many of those are currently children?
We do not have, we have that information, but I do not have that on the slide. I can get that for you, Senator Carroll.
Okay, and on the waiver redesign, the process we've been going through, and I know there are components of that being addressed, but overall, where does that stand? I know there was discussion about standardizing the waivers and then more a la carte services based on the individual's needs. Where does that stand now?
So we currently have our 6 home and community-based waiver applications with CMS waiting on approval. It does have the updated rates in there. Is there a specific service that you're requesting?
No, just in general, the structure of the waiver services themselves, that there's been a lot of study over recent years. Are all those things included in this application with CMS?
Over the years, we have made several changes to our home and community-based waivers. I think that the guidance with the regulations that are coming out, I think that will make it a little bit more clear with policies and aligning across waivers. I believe that's your question, is aligning those policies across waivers so that there's no disconnect in the delivery of services from one waiver to another.
Okay. And just one final quick question. With the EPSDT services, does CMS say anything in their language about who makes that determination as far as medical necessity?
No, there's no definition of medical necessity or who would make that determination. We will go back and review that guidance. But typically with medical necessity determination, there are a couple of software applications that are used, such as Milliman or Interqual. Those sorts of things are used to determine medical necessity. But with the EPSDT benefit, what should happen is if a child is denied a service, there should be a peer-to-peer review with the provider from the managed care organization, for example, and the facility, and they should walk through that and see if that child, for some reason, their medical needs, there may be something that's unique to that child that maybe falls outside of that medical necessity criteria that should be evaluated and looked at with a peer-to-peer review between providers of like disciplines.
And is that language in the contract with the MCOs?
I'd have to go back and double check that EPSDT language.
Thank you. Thank you, Mr. Chairman.
All right. That concludes our discussion for today. Commissioner Lee, appreciate you folks being here today. Again, a wealth of information. Great questions from the committee members, and I appreciate the discussion that we've had, but there's no further business coming for us. This meeting stands adjourned.